Hello, I'm Anjlee Mahajan, and I really appreciate the opportunity to be here. On behalf of my colleagues at the University of California, Davis, we're excited to present our work, Fragmentation of Care for Young Adults with Sickle Cell Disease in California. So by way of introduction, as many of us know, sickle cell disease causes significant morbidity and mortality for those that are affected. And in the United States, children are often more likely to receive comprehensive care than their adult counterparts, and this may lead to improved outcomes. The idea of a medical home, or one particular place where patients can receive comprehensive care for their chronic illness, has been studied in multiple different diseases, including sickle cell disease. However, young adults may not always have this option of this medical home, as they're in a period of transition from the pediatric to adult care models. They're also in a period of transition in terms of physical location. They often move at this time period in their life. They're also in a period of transition in terms of insurance. Sometimes they may lose insurance or switch insurance during this time period as well. All of these social risk factors can lead to potential increases in fragmentation of their care. And in this study, we really wanted to examine and characterize the fragmentation of care for young adults with sickle cell disease and contrast that to younger patients and older patients and determine if there was a potential association of fragmentation on mortality in this population. So, using administrative data sets from the state of California, we were able to identify sickle cell disease patients through discharge coding from 1991 to 2016. The patients were then placed into 3 separate cohorts, all with a 7-year follow-up time period. So we defined children as being 10 to 17-year-olds, young adults being 18 to 25-year-olds, and adults being 26 to 33-year-olds. We classified fragmentation as the number of unique facilities that an individual received inpatient care at during their time in each age group. We then defined facilities in the top 5% based on number of unique sickle cell disease patients that were seen and considered these to be sickle cell disease specialty care centers. We performed regression models to identify risk factors associated with fragmentation, as well as to determine if there was any impact of fragmentation on mortality. And here are our results. So we were able to identify nearly 7,000 patients in the state of California with sickle cell disease. There were about 1,000 patients in the children cohort, 1,100 patients in the young adult cohort, and 1,000 patients in the adult cohort. And all patients had to complete the entire 7 years follow-up time when they were in the cohort. So this graph shows fragmentation of care for sickle cell disease inpatient admissions based on age. So as you can see here, the blue graph represents 1 facility, red is 2 facilities, gray is 3 to 4 facilities, and the purple is greater than or equal to 5 facilities. So children, nearly 60%, were most likely to be seen at just 1 facility. And this was sharply contrasted in young adults and adults, where about 20% were seen at 1 facility. Therefore, most young adults and adults were seen at multiple facilities. So with even 20% being seen at 5 or more facilities in just 7 years. So, I mean, imagine what that would be like to have a chronic debilitating illness and to have to go to multiple different hospitals during this vulnerable time period in your life and being seen by different care providers who may not know you and may not have all of your records as well, and how this might impact your outcomes and the quality of the care that you receive. When we looked at risk factors for fragmentation in this age group, what we found was that those without insurance, those with more frequent admissions, so more than 10 admissions in a 7-year time period, and those who were not always seen at a sickle cell disease specialty care center were at highest risk for fragmentation. And while we initially thought that fragmentation might be associated with an increased risk of mortality, when we actually did a multivariable model to look at this, what we found was that it was really frequency of admissions, so more than 10 admissions in a 7-year time period, those patients were at the highest risk of mortality in the young adult age group. So in conclusion, what we found was that most young adult sickle cell disease patients, up to 78%, actually received their care at multiple facilities, whereas children were most likely to be seen at just one facility, which suggests that fragmentation of care begins in early adulthood and continues on as patients age as well. So risk factors for fragmentation of care in the young adults included lack of insurance, more frequent admissions, and care outside of a sickle cell disease specialty care center. Fragmented care for young adults was actually not associated with an increased risk of mortality after we adjusted for other variables. And those more frequent admissions were at the highest risk of mortality. We are planning on performing future studies to examine the effect of fragmentation of care on sickle cell disease complications, including acute chest syndrome and stroke. And I think the main point of the study is what can we do as providers and a healthcare system to really improve the comprehensive care that young adults likely need and that are not appearing to be receiving as compared to children. And as more therapeutic advances are coming down the pipeline for sickle cell disease, it seems even more imperative that patients receive comprehensive care from providers with expertise in the field. Thank you.